You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 25th, 2023. This week, 2 early studies from the ESC, one on GLP agonists and HFpEF, the other direct-acting oral anticoagulants for subclinical AF. I'll also talk renal denervation and the matter of remaining a profession. Now, I'm broadcasting from the ESC meeting in Amsterdam. First of all, I love this city. I hired a bike, and I'm using it for transportation, and it's fun as heck. I look forward to seeing familiar faces and meeting new colleagues. Please say hello at the meeting. I want to first start this podcast with some listener feedback. Dr. Doran Zager, in a comment on our website, rightly pushed back on one of my comments that I made last week. In making the argument that ICD therapy likely has no substantial effect on mortality reduction in patients with non-ischemic cardiomyopathy, I cited the subgroup analysis of SCUD-HEF. I took the view that most of the average benefit in SCUD-HEF concentrated in the ischemic cohort. Remember, in SCUD-HEF, it was about 50-50 ischemics and non-ischemics. But DZ rightly points out that A, trials are powered for the overall population, and we should be very cautious making claims from subgroups, and B, that actually, in the ICD arm of the SCUD-HEF subgroup, in non-ischemics, the p-value was 0.06. He is absolutely right, and as I was going through the discussion, my imaginary friend here in the back of my brain was saying, be careful, John, with that SCUD-HEF bullet point. I should have spoken more clearly about it. Thanks for listening so intently and taking the time to write, and I love these comments. Now, TWIC podcast comes out every Friday, and due to the time delay today being in Europe, I can actually cover some of the first hotline trials and still be within the embargo. There won't be much time for commentary or deep thinking on them because they just came out, but I can offer some top-line results and some quick thoughts. The first hotline is a trial called STEP-HFpEF. The trial combines 3 of the biggest topics in medicine today: the GLP-1 agonist, obesity, and HFpEF. Now, HFpEF, or heart failure with preserved ejection fraction, is the most common cause of heart failure. Obesity is surely a condition that worsens quality of life in patients who have HFpEF, and obesity is also a likely cause of HFpEF. The GLP-1 agonists have clearly been shown to induce serious weight loss in patients with obesity. And so STEP-HF combines these 2 givens. That is, if the drug induces weight loss, it also to improve functional capacity and quality of life. So the trial had about 500 patients with HFpEF and obesity. One group gets semaglutide, the other placebo. Patients had to have a BMI of greater than 30 kilograms per meter squared, and they had to have an ejection fraction of greater than or equal to 45%. Defining HFpEF meant having an elevated filling pressure at cath, or an implantable monitor, or elevated NT-BNP with typical echo features of HFpEF, or a hospitalization for heart failure requiring IV diuretic within the previous 12 months, and then 2 other clinical hemodynamic echo features of HFpEF. In other words, they were pretty careful in this trial to get patients with HFpEF. Now, from the protocol paper, we already know the baseline characteristics of the enrolled patients: average age, 69 years, average BMI, well greater than 30 at 37. 56% were female, the mean LVEF 57%, half of the patients had AFib, 80% had hypertension, 1/3 had coronary disease, Follow-up of STEP-HF is 1 year. They had a dual primary endpoint, which was weight loss and quality of life as measured by the KCCQ, which is, of course, how patients judge their well-being on multiple parameters. And the plan was that if both of these endpoints met statistical significance for superiority, then investigators will test secondary endpoints in sort of a hierarchical fashion. First, they did a win ratio of multiple outcomes. Then they did a 6-minute walk test. Then a ratio of CRP, a measure of inflammation. Now, recall that a win ratio is an analysis wherein participant pairs are compared to see which one wins, which means avoiding the bad outcome. The win ratio is basically a proportion of winners randomized to semaglutide divided by the winners randomized to placebo. And here were the results. I mean, I don't think we should be surprised. The mean changes, the improvements in KCCQ were double the size in the semaglutide arm. It was highly significant and clinically relevant. Weight loss was greater in the semaglutide arm, about 13% loss of body weight in the semaglutide arm versus 3% in the placebo arm. That too was highly significant and surely clinically relevant. And since both of the primary endpoints were significant, the authors reported the secondary endpoints, 6-minute walk test, much better, win ratio better on semaglutide by a whopping 1.72, so 72% better, which was also statistically significant, and a mean change in CRP for semaglutide versus placebo, minus 43% versus minus 7.3%, which was also significant. Now, the Heart.org Medscape Cardiology has a nice discussion from a few weeks ago on GLP-1 agonists for HFpEF. I will link to it, and I'll make some comments about that discussion here in sort of thinking about the results of this paper. The first thing I noted about that discussion was how common obesity is in patients with HFpEF. I mean, here in Kentucky, I suspect obesity rates in patients with HFpEF are well greater than 60%, or maybe even higher. Now, in the discussion, the two doctors focus a lot on inflammation, which is a key driver. Inflammation is obesity, of course. So semaglutide induces weight loss, and as seen in the results, the CRP levels fall substantially. But I think explaining the benefits in STEP is more obvious than in citing any inflammatory pathway. Patients who have a mean BMI of 37, as it was in this trial, who then get an 11% reduction in the percent of body weight, are going to improve quality of life and walk time. I can't cite the exact physiology studies, but I'm nearly certain that LV diastolic parameters are also going to improve with weight loss. But of course, HFpEF isn't just a heart condition, it's an all-over condition. And anything that induces that much weight loss in severely obese patients is going to help globally. Again, the tension here is, if you use evidence to practice medicine, this is very strong evidence for benefit in patients with a serious health condition, that is obesity and HFpEF. And using this drug in the longest term is not such a big deal for people nearing their 7th decade or in their 7th decade. It's a much different calculus using these drugs in adolescents or young adults who have isolated obesity and may be facing many decades on a drug. Finally, though, I'd love to be able to induce this sort of weight loss with a lifestyle that I am immersed here in the Netherlands. I mean, you see so few obese people commuting around helmetless on bikes. Now, I realize that we can't, of course, transport Dutch living everywhere, but when I wear my science hat, I really wonder whether weight loss with diet, exercise, and lifestyle changes wouldn't even exceed the benefits of GLP-1 agonist. While this drug class is clearly effective, my worry is that these drugs may well treat a problem now, as in the present, but their success may actually worsen societal norms and move us further from the Dutch ideal that I see when I ride my bike to the Congress. Next topic today is the NOAA trial. Now, it is said that you learn as much from trials with a non-significant primary endpoint as you do from positive trials. That is surely the case for NOAA AFNet 6 trial, presented as the second hotline here at ESC. The primary endpoint of NOAA may be statistically non-significant, but the results are highly, highly significant clinically and scientifically. Now, there was a press release. The study was stopped prematurely because of futility. We know that. I wrote about the NOAA study in my ESC preview, but I didn't get the whole story. The data presented here are even more impressive and even more, I think, practice-changing. Here's a very brief recap. Some basic facts. Everybody knows AF increases the risk of stroke. Everybody knows there's a gradient of risk based on the presence of stroke risk factors such as age, hypertension, heart failure, vascular disease. Everybody knows that oral anticoagulants given to people with risk factors reduces the risk of stroke, but these trials that showed this were done in an era when you had to have enough atrial fibrillation to get it documented on a standard ECG, usually in a doctor's office. But now things are different. Now we have devices that can capture very short duration episodes of AFib. In fact, all modern dual-chamber pacemakers and ICDs have technology that detects even minutes of atrial fibrillation. Now, sometimes these are called atrial high-rate episodes because no one actually knows the actual duration when a super-fast atrial high rate turns into actual AFib. Dr. Paulos Kirchhoff, the primary author of NOAA, did show in his presentation an example of an atrial high rate episodes. And my friends, this is atrial fibrillation. It is irregular, rapid atrial activity. In their well-written introduction, in their rationale paper, American Heart Journal, I'll link to it, the authors tell us the big four uncertainties of these atrial high rate episodes. First, we don't know the prognostic meaning of short duration AFib. Most of the observational studies which find that these episodes associate with an increased risk of stroke also find a low absolute yearly risk of stroke. That's a critical point because there is a threshold risk in which bleeding from oral anticoagulation outweighs stroke risk. I mean, that's why we use the CHADS-VASc score. Second uncertainty. A lot of atrial high rate episodes are not precursors of AFib and don't turn into full-blown AFib. Third uncertainty, the timing of atrial high rate episodes are not closely tied to strokes. The lack of what's called temporality in the language of Bradford Hill suggests that there may be other mechanisms of cardioembolic stroke besides the high rate episodes. Fourth uncertainty, not all atrial high rate episodes are actually arrhythmias. Some are actually artifact, aka false positives. So with that as the uncertainties, here are the nuts and bolts of the NOAA trial. Patients were those who had pacers or ICDs and had atrial high rate episodes greater than 6 minutes, and these patients had to have greater than one risk factor. They were randomized to the DOAC edoxaban or placebo. The primary endpoint was a composite of stroke, systemic embolism, and CV death, but they also looked at the more typical stroke and systemic embolism secondary endpoint. On the surface, it seems like a big trial, right? 2,500 patients, but recall that the NOAC versus warfarin trials enrolled more than 10,000 patients, and these were patients who had clinical AFib. The mean age in NOAA was 78 years, slightly more than a third were women, and the median duration of the atrial high rate episodes was 2.8 hours. The trial was terminated early at a median follow-up of 21 months. And here is what I learned that is new. It was stopped for futility, we knew that, of efficacy, but it was also stopped for safety concerns. A primary endpoint occurred at a rate of 3.2% per patient years in the edoxaban group versus 4% in the placebo group. The hazard ratio for efficacy was 0.81, but the confidence intervals went from 0.60 to 1.08. And the p-value was 0.15, so non-significant, clearly non-significant. The incidence of stroke was about 1% per patient year in both groups, so a very low incidence of stroke. But safety was worse in the edoxaban arm. A safety event occurred at a rate of 5.9% per patient year in the edoxaban group versus only 4.5% per patient year in the placebo arm. That's a 31% higher rate of harm, and it was statistically significant, with confidence intervals ranging from 1.02, that's 2% worse, to 1.67, or 67% worse. And Dr. Kirchhoff said that most of the increased hazard was due to major bleeding. The rate of ECG-diagnosed AFib in the entire cohort was 18.2%, or 8.7% per patient year. Translation, less than 1 in 5 patients who had atrial high rate episodes went on to actually get full-blown AFib. All right, comments on NOAA. Oh boy, this is really important data. Here we have older patients with risk factors and a median of nearly 3 hours of atrial high rates, which is also called subclinical AFib. Really, this is AFib. And with edoxaban, no significant reduction in stroke, and a statistically significant, clinically important, higher rate of bleeding. That is huge. This is a really important finding. For proponents of AFib screening with any device capable of finding short-duration AFib, this is like an existential punch in the gut. The net benefits of AF screening were already in question after the non-significant findings of the LOOP study, right? AF screening with implantable loop recorders in high-risk patients found non-significant stroke reductions, non-significant increases in bleeding, basically a null trial. Now we have a direct test, an RCT, of treating patients with short-duration AFib, and it was terminated early for futility and higher rates of bleeding. Now, proponents might say, come on, Mandrola, the primary endpoint hazard ratio was 0.81. That's near 20% reduction. Had the trial been not terminated and continued longer, that might have grown to significance. The problem with that argument, and my counter is, and I see this every day, right, because people I work with, including myself, are inclined to treat these short-duration AFibs when we see them, rather than not treat, is that if you had continued the trial longer, bleeding was increased in the edoxaban arm, and it might have gotten worsened with a longer trial. I'll recall that in the LOOP trial, the non-significant rates of stroke reduction were balanced by the same non-significant increases in bleeding. This is the issue with treating these short-duration episodes. So some big take-homes. Next week in clinic, when I go home from Amsterdam, when I get a message that our patient with risk factors has, quote, AFib on their pacer or Apple Watch or loop recorder, what NOAA and, of course, LOOP teach us is that the concept of atrial fibrillation has changed. Not all AFib is the same. Before ESC, before LOOP, we had no idea of the threshold for using oral anticoagulation in AFib. NOAA teaches us that it's likely greater than 3 hours, at least in patients like those in the trial. Now, we still have Artesia trial out there. This is a similar trial testing apixaban versus aspirin for subclinical AFib greater than 6 minutes. Its expected completion date is December of this year, and it has not yet been terminated. Now, the problem with Artesia is that I worry about the choice of aspirin as the control arm, right? Why? Why do I worry? Because aspirin has no benefit in stroke prevention in AFib, but it will surely increase bleeding. So if you increase bleeding in the control arm, any rise in the control arm bleeding may mitigate a delta in bleeding between the two groups. All right, third topic today is renal denervation. This has nothing to do with the ESC, but renal denervation did make news because it went to the FDA advisory committees. Now, what a ride renal denervation has had. First, there was the sheer glee in the early non-sham controlled trials, which found massive blood pressure lowering effects with the procedure. And then just one sham controlled trial called Simplicity 3 shattered all of this joy with its essentially negative results with the sham control. Then the renal denervation innovators went back to the drawing board. They refined the procedure. They developed two kind of catheter paths. One is an RF catheter, the other an ultrasound catheter. They also cleaned up the trials. They paid more attention to standardized medical regimens in the trial. And this week, both systems, the ultrasound system made by a company called Recor and the radiofrequency spiral system by Medtronic, face scrutiny from FDA panels. Now, recall that advisory panels are just that. They hear evidence from the company, FDA officials, patients, and they vote on specific questions. Their rulings may influence official FDA rulings, but they are just a panel, an advisory panel. The ultrasound system got a positive vote. The Medtronic system did not. Well, this is a complicated space with trials looking at blood pressure on and off medicines, and I'm not going to go over all of them. In brief, the positive vote for the ultrasound system turned on 3 trials. Radiance Hypertension Solo, about 140 patients, 2 months, mean change of blood pressure, 6 millimeters per mercury in the renal denervation arm. Second trial, Radiance Hypertension Trio, about 200 patients, 2 months, follow-up mean change about 4 millimeters of mercury. Radiance 2 trial, 150 patients, 2 months, mean change about 6 millimeters of mercury. So the panel were unanimous on safety. They were 8-3 on yes efficacy, and they were 10-2 on benefits outweighing risks. The big problem, though, and everyone agrees, is that we don't know about the durability of effect. These are very short duration follow-up trials. Another issue that came up is that the company is asking that the device be used in patients who inadequately respond to or are intolerant of blood pressure meds, but this isn't really what was studied in the Radiance trials. That issue reminds me of the left atrial appendage occlusion issue, right? Because that device was approved for patients who were basically excluded from the seminal trials. Now, the next day at FDA, the panel came to different conclusions on the spiral renal denervation catheter from Medtronic. Here, there are 2 influential trials, the spiral hypertension off-med, Lancet 2020, about 320 patients, and about a 4 millimeter drop in blood pressure at 3 months. Then spiral hypertension on med. It was presented at AHA 2022. It did not meet its efficacy endpoint for differences in blood pressure. The FDA panel was again unanimous on safety, but they were 7-6 for efficacy, but they voted 6-7 against on benefits being greater than risks. Now, my comments. I don't know what FDA will do, but I really worry about this procedure in space. My main issue with this procedure sort of centers on efficacy. 2 efficacy issues. One is that these are fairly modest reductions in blood pressure, and we have no idea on long-term durability of the effect. If FDA approves these devices, I will have to say I don't understand regulation, and here is why. The main question is whether this modest effect lasts more than months, and, of course, whether it reduces outcomes. All of the regulatory bodies have to do is force companies to run longer sham-controlled trials, and we would know. I mean, the nanosecond that you break blinding, you lose any ability to infer effect size. For instance, a paper published last April in The Lancet called Long-Term Efficacy of Spiral Hypertension Med Trial purported to show long-term effects out to 3 years. But I think this is an incorrect conclusion because in this analysis, blinding was terminated at 6 months. So anything after that, years 1, 2, 3, you can't really say anything without blinding. So I have this tension with renal denervation. On the one hand, this is an interesting technology, and the investigators deserve credit for iterating and improving on the early techniques. And if renal denervation worked in the long term, it would be a huge thing because medicine and lifestyle modifications for high blood pressure are hard to comply with. But if you think expensive, likely low-value procedures like appendage closure and pulmonary artery monitoring are overused, renal denervation could dwarf them all because hypertension is so prevalent. And if the labeling is for patients in whom blood pressure medicines are not tolerated and reimbursement from payers is generous, renal denervation could break the healthcare budget. The simple solution, I think, is right before our eyes. Just do longer trials that maintain blinding. It can be done. All right, final topic today relates to a maintenance of certification debate that is going on in the U.S. There's been a rekindling of this debate regarding the certification of physicians. And I realize this podcast has many international listeners, and I'm grateful for it. So I will keep my comments brief and also try to hit big theme items rather than the specifics. I suspect this debate pales in comparison to what British colleagues are dealing with in the NHS. The gist of the MOC, or Maintenance of Certification issue, is that the American Board of Internal Medicine has changed the rules of continuing to be called a board-certified physician. Now, that is more than a label, because being board-certified generally equates to being able to work as a doctor. When I started medicine, all you needed to do after residency or fellowship was pass a test and you were good for life, as long as you did the right amount of CME and you kept up your privileges. The next step that ABIM came up with, they said, no, medicine is changing too fast. Now you need to do another big, high-stakes, expensive test every 10 years. I've passed electrophysiology boards 3 times, and 2026 will be number 4. That is, if the world and I last until 2026. But now it's even worse. Now the ABIM requires you to do and pay for something called longitudinal knowledge assessments, LKA, every year. Now, these are open book tests that some say test how fast you can use Google. For instance, a person could finish a residency and fellowship, pass the big first test, but if he or she does not pay and do the longitudinal knowledge assessments the very next year, they are no longer certified. And this is nuts, because the most up-to-date doctors in the world are those just out of fellowship and fresh off passing their first medical board exams. Now, the big picture specific issues, and I'm going to surely miss some, are that ABIM is an unaccountable organization. ABIM has relationships with other healthcare organizations and professional societies like ACC and HRS. ABIM isn't exactly transparent with their finances. ABIM has ensured a monopoly because boards of licensures, hospital organizations, and payers require it. And there exists no evidence that ABIM-branded medical education is better than any standard CME. Now, I'm going to note 2 of many general themes in this debate. One is that the debate is occurring on social media, particularly in the realm of podcast. The debate has to occur outside of medical societies and journals, because many of our societies make money selling test prep. In other words, classic conflict of interest. My friend, oncologist Chadi Nabhan, hosted a debate featuring practicing hematologist Aaron Goodman and the CEO of ABIM, Richard Barron, on his Healthcare Unfiltered podcast. Another friend of mine, Dr. Wes Fisher, a practicing electrophysiologist, has been really in the forefront representing practicing doctors using his blog. That's right, a blog. Long form is the point. I may be wrong, but I think platforms that allow for long-form debate are a hugely positive thing for medicine and actually for society in general. Keep in mind that the most popular podcast in the world routinely has 2 to 3 hour long discussions. Moving away from these 2 to 4 minute sound bites or these rapid-fire presentations is really a huge positive. Another global point to make here is that the reason American physicians will not win against unaccountable rent seekers is because we are not organized. Just stop and think, for instance, at the basic hospital level. Picture yourself walking into a hospital. Have you ever thought that all of it, I mean all of it, the structures, the people there, the whole place exist only because clinicians see patients and send bills to payers for their work? If not for the working stiff clinicians, none of this exists. So if we were organized, we would have influence. But I am pessimistic that we could ever organize. When I began cardiology private practice, it was a constant struggle to keep 20 cardiologists together in one group. We were eventually broken up when hospitals started employing doctors. So I guess my message is that until we in the profession support each other and organize together, we will be susceptible to these arbitrary rules and rent-seeking, unaccountable organizations. Now, obviously, I'm in the second half of my career, and I'm going to watch how our profession transforms itself over the coming years. But if we are to remain a profession, we must find a way to organize. Professional societies, I am afraid, are not the answer for us. So that's it for this week. Next week, I'll have many more studies from ESC It'll be a very busy podcast with lots of great stuff coming from the meeting. As always, remember, if you like this podcast, please take the time to give us a rating on whatever podcast app you use. Also, the comments that I've been getting are great. I really appreciate it. Thank you. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.